Um, so thank you. Yeah, it's really a pleasure to be with you all here today. And I was asked to talk about new targets. So I'm going to really focus less on standard therapy for T-cell lymphoma and talk about some new targets, some of which are already available in the clinic and where our understanding is increasing, and some of them that are still in clinical trials but maybe coming down the pike. Sorry. Can I advance? Let's see if that works. These are my disclosures. So I'll really talk about some newer therapies, start with some epigenetic therapies, which many are available, though there are some new ones, then talk about some earlier work on some signaling targets, and then a very little bit on some immune therapies or surface targets that we and others have been working on. So I think, when we started by talking about a T-cell lymphoma, particularly to an informed audience, I won't go into all the background details, but as you all know, this is a heterogeneous disease. We don't do nearly as well in terms of therapy as we do for B-cell lymphomas. But we do have some agents that have been looked at and sort of identified for specific activity or reasonable activity in T-cell lymphomas. And at least what we have here available in the US and in much of the world are a couple of HDAC inhibitors, belinostat and romidepsin. Hopefully you can see my pointer there, sort of the top and the bottom, are single agents that have a 25 to 30% response rate in peripheral T-cell lymphoma. Romidepsin a little bit more in cutaneous T-cell lymphomas. Some patients having complete responses, and when those are used, they can achieve disease control. And if you look at the durations of response there, some patients with continued therapy can have some maintenance of response. As you all know, the one, very potent or very active agent we have in T-cell lymphoma is brentuximab vedotin, where at least in the anaplastic large cell lymphoma subset with high universal CD30 expression, we have very high response rates in the relapse setting. We have high rates of complete response. And as you know, when that's combined in the upfront setting, there's an overall survival benefit when added to CHOP-like chemotherapy. In other types of T-cell lymphoma, we see okay responses to brentuximab. If there's any, often very little CD30 expression, we do see responses. And in a small phase 2 of PTCL and AITL, the response rate was about 40%. Some of those completely, not nearly as durable as we see in anaplastic large cell lymphoma. And then pralatrexate, which was initially developed here, again, has just less than a 30% response rate in peripheral T-cell lymphoma. So there are a subset of patients that have a very good response to that, but the majority of patients either won't respond or would progress after some time on therapy. So there's certainly a high unmet need and a lot of work going on to identify new therapies. I think most of our understanding in terms of really useful other therapies has been in other epigenetic targets. Either in terms of better understanding of disease or better matching with patients. So again, as probably many of you know, that angioimmunoblastic T-cell lymphoma, which is now lumped in with what we call a T follicular helper T-cell lymphoma. So those are cancers of a follicular helper T-cell, so a specific cell of origin. They often develop on a background of clonal hematopoiesis. So we typically see things like TET2, DNMT3A, and it's probably some additional mutations. Some of the best characterized are RhoA, IDH2, there's some VAV1, but some additional mutations on that backbone really lead to the development of this lymphoma. And in this nice review here by Javid Iqbal's group and Taylor Havikan, they really have a nice way of kind of subsetting some of the aggressive or systemic T-cell lymphomas. And there's a group that really are, the hallmark are these epigenetic changes, and those are most likely these follicular helper T-cell lymphomas. And we've recognized first by suspicion and then some confirmatory studies that even though many of the mutations are in methylation, that drugs that target acetylation have higher response rates in the follicular helper T-cell lymphoma subset than in the other subtypes. So this was work done by Paolo Ghioni, who is a fellow with us and is now faculty with us, just sort of looking at responses in follicular helper T-cell lymphomas or non-follicular helper T-cell lymphomas with HDAC inhibitors. And what you can see from here is that there's quite a bit higher response rate in follicular helper T-cell lymphomas, both in terms of overall response and complete responses. And this is some data lumped in with single agents as well as combinations. And then I think, as people are also familiar with, there's been an experience with azacitidine from from France, where looking at a series of patients treated with azacitidine, there was particularly high responses in angioimmunoblastic T-cell lymphoma compared to other peripheral T-cell lymphoma. And that was a small series. It wasn't really a prospective study. There's a follow-on study testing that formally, which is not yet reported, but we hope to hear that data at ASH. And then there's been work in building multiple epigenetic drugs together. So this is work by Dr. Owen O'Connor's group at Columbia, combining azacitidine with romidepsin and showing that that combination together can be, again, particularly active in patients with follicular helper T-cell lymphoma. This look was extended into a study in France looking at combining romidepsin with CHOP chemotherapy and randomizing it against CHOP. So based on some phase 1 and phase 2 data, it appeared preliminarily that romidepsin plus CHOP might be more potent than CHOP alone. When a large formal randomized study was done, there actually turned out to be no difference. If you look in the bar graphs on the right, the overall response and complete response were very similar between the two groups. And if you look at the progression-free survival curve in the middle, while the green curve, which is romidepsin plus CHOP, kind of sits above the orange curve, which is CHOP, it was not statistically different and no real difference in overall survival. Part of that may not have been the efficacy of romidepsin, but it may have been the added toxicity. So I think when we looked at brentuximab plus a CHOP backbone versus CHOP, one important thing that probably, partly led to the benefit of that experimental arm adding brentuximab was we really didn't see excess toxicity. When romidepsin was added to CHOP, we do see higher rates of primarily hematologic toxicity that have led to more frequent dose reductions or dose interruptions and eroded sort of the dose intensity of the regimen. So I think that may be one of the reasons, and that may just be a factor of adding romidepsin to chemotherapy. I think the other thing that comes out if we look at the forest plots here, subset data, and again, this wasn't a pre-planned subset, so we have to take it with a grain of salt. But if you look just in the red box at the angioimmunoblastic T-cell lymphoma patients, which were about half of all the patients, the point estimate is far to the left of 1, and the confidence intervals just cross 1. And one can imagine, if we're being optimistic, that a study just in those patients, or even a more powered subset of those patients, might have shown a benefit. And actually in the paper, in the supplemental data, they did look at those patients independently. And it does look like if there's a benefit adding romidepsin to CHOP, maybe it's in this subtype. Following along with that same idea, Girouan at Cornell had looked at combination of azacitidine plus CHOP. So again, azacitidine to overcome or reverse chemo resistance has been looked at in diffuse large B-cell lymphoma, and it's been safely considered combined with CHOP. And what the study that Gia led was looking at that same approach in T-cell lymphoma. So adding oral CC486, which is an oral form of azacitidine. Here's the schedule here. So it's actually given before the chemotherapy to try to induce sensitivity, and then followed by chemotherapy. This is a phase 2 study, so small study, 21 patients. Those are the patients shown there. And you'll see that the majority of patients, partly because this was our bias of who it would most help, but 17 of the 21 patients have had a follicular helper T-cell lymphoma subtype. And the data that she has presented, and the study now has longer follow-up, showed that the overall response, if we look at the end of treatment response, overall was 75% of patients responding, all of those completely. And in the follicular helper T-cell lymphoma group, 88% patients had a complete response. So again, this is an academic center study. Comparing it to historical or larger data sets, has to be done with caution. But if anything, this looks quite potent and looks like a high CR rate. And with relatively short follow-up, you can see that the majority of patients there do maintain their remission. So with longer follow-up, we'll sort of see how this plays out. This is now the standard arm in a cooperative group study, so we'll get more data on that. If you just look at the toxicities down on the bottom left, you'll see that there was frequent hematologic toxicity, which we see with combination chemotherapy. Maybe, maybe not, but maybe that was increased a little bit by adding azacitidine. I think the other new epigenetic target that we're pretty excited about is valemetostat. So valemetostat is an EZH1/2 inhibitor, and it's been studied in a phase 1 study in peripheral T-cell lymphomas, initially in Japan, and then an extension study or expansion in the US. And then this led to a phase 2 study, which has actually completed accrual, um, but um, but we don't yet have data on. And if you look at the data from the phase 1 study, I'm assuming you can hear me okay. I saw a hand come up, but we'll do
No, it's
questions
good.
at the end.
We can hear you.
Okay, good. Yeah, I didn't know if someone was trying to tell me like my audio was off or something. Um, if you look at just the results of the phase 1 study, so the phase 1 expansion of peripheral T-cell lymphoma was over 40 patients, so not a huge study. But for PTCL, not smaller, our registration studies had only about 100 or 120 patients. You see the overall response rate overall was over 50%. Half of those were complete responders. And in particular, among the angioimmunoblastic subtypes, of these again are the follicular helper T-cell lymphomas, we saw high rates of response and high rates of complete response, almost 50% there. So I think that again kind of fits this narrative that I think most of us believe, which is that we have these active drugs that on epigenetic targets, and if anything, those benefits are most seen in people with the T-cell lymphomas that develop on these mutations in epigenetics. When you look at the duration of treatment for patients on balimetastat, so this is an oral drug. It does have some side effects like thrombocytopenia, but it's relatively well tolerated. You'll see that a large number of patients here with the arrows and in the green have ongoing responses. And we have seen patients been able to maintain responses on this drug. We have a few patients that are several years out from the phase 1 study, and it looks like the drug can be given long-term without cumulative toxicity. So this drug looks like it has potent single-agent activity, and then next questions will be sort of where to go from there. So just to summarize in terms of epigenetic modifiers, these are among the most studied drugs in T-cell lymphoma, HDACs, which are standardly used, DNA methyltransferase inhibitors like azacitidine or similar drugs. Early data, we'll be getting some follow-on data. And then investigational use of EZH inhibitors is ongoing. And hopefully in the next year or so, we'll have data from the phase 2 study and see if that maybe moves forward as a single agent. As I mentioned, we know that particularly the AITL or the follicular helper T-cell lymphomas are enriched for mutations in epigenetic modifiers, mostly histone or methylation DNA modifiers. And again, we see this correlation between those drugs that target those mechanisms have the highest rates of response in angioimmunoblastic T-cell lymphomas. And as you see below there, the next step often for these drugs in T-cell lymphoma is to try to move them into frontline setting to see if we can increase cure rates rather than just managing disease in relapse. Move on to some of the other signaling targets that we and others have studied. And the most data right now is with targeting the JAK-STAT pathway or targeting the PI3 kinase pathway. So this is a study that was published in Blood actually last year by my colleague Alison Moskowitz, looking sort of at a proof of principle study of looking at treating patients with relapsed T-cell lymphomas with ruxolitinib, so a JAK1/2 inhibitor. Part of the reason we picked ruxolitinib was because it was FDA approved. We had a safe dose and schedule, and really looking at a principle is whether there was activity here. Would targeting this pathway alone be adequate? We divided patients into 3 groups based on what we thought were their biology and likelihood of response. So group A were patients who had activating mutations in the JAK-STAT pathway. Most of these are STAT mutations, but some are mutations in JAK. Group B are patients who didn't have a mutation, but had functional evidence of that pathway being important. So this was mostly high levels of phospho-STAT3 on immunohistochemical staining, suggesting that pathway was upregulated in those patients. And then group C either had neither of those or were unknown. And each of these was done in a 2-stage phase 2 design. When we looked at this in terms of response rate, we see that there is some correlation with response and biomarkers. If you just look at the response rate, again, it was about 30%, which we've seen for many of the other treatments in T-cell lymphoma in patients in group 1 or group 2 who had some evidence of JAK-STAT pathway being important in the pathogenesis or the proliferation of their lymphoma. We added this clinical benefit rate because with this drug, we saw a number of patients who didn't meet formal response criteria, but who had prolonged 6-month or longer stable disease or disease without progression or improvement in disease short of a partial response. Some of those were the LGL or the PLL patients. And if we look at that more broad, looser definition of clinical benefit, we see the response rates go up. And if you look at cohort C that didn't have evidence of JAK-STAT pathway being important, we saw relatively lower rates of response or clinical benefit. If you look at that in terms of subtypes, and I think one of our thoughts in these pathway targeted drugs is the mutations or the pathways don't exactly map subtypes, but some subtypes are more frequently enriched for certain mutations. We saw reasonable responses in patients with PLL, which is a very difficult to treat disease, but frequent with JAK mutations. We saw high rates of response and clinical benefits in patients with LGL. And actually, that's now expanding into a separate study for LGL because the clinical benefit rate, if we look at improvement in cytopenias, has been around 70 to 80%, with now about 15 or 16 patients with LGL treated. So we think that ruxolitinib may be an effective therapy for that disease. And then again, here we see reasonable rates of response in angioimmunoblastic T-cell lymphoma, which we're not completely sure why. Mutations in the JAK-STAT pathway are not typical for AITL. We talked about the mutations in epigenetic modifiers, and there it might be a microenvironment effect because the JAK-STAT or JAK inhibitors may have an effect on the microenvironment, and we believe the microenvironment, may be more important in a lymphoma supporting role in AITL than some other types of T-cell lymphoma. Kind of some one-off responses, patient with gamma delta T-cell lymphoma, which often have STAT mutations. One subtype that was looked at that we think may be particularly susceptible to JAK inhibition was something called primary cutaneous aggressive epidermotropic T-cell lymphoma. So I don't know how many people are familiar with that. It's a very rare lymphoma. It develops in the skin. It's an aggressive CD8 positive lymphoma with these cytotoxic T cells that tend to be very destructive. Our standard therapies for this are typically combination chemotherapy and allotransplant. And Jay Choi at Northwestern, working with Dave Weinstock in Boston, noted that in laboratory models of patients with this aggressive cutaneous lymphoma, that there was a very typical JAK2 fusion that was highly frequent and really characterized this disease. And when they did some preclinical look, it looks like targeting the JAK-STAT pathway may be an effective therapy. So we opened a small cohort on that study, and that cohort is still ongoing. We've just treated 2 patients on that cohort, but this was the first patient we treated with this disease with ruxolitinib. So he came into the hospital really with very destroyed skin. Clothes were actually stuck to him because of all the weeping, and started oral therapy with ruxolitinib and had a very prompt response with significant improvement in reepithelialization of his skin. So we saw that very dramatic activity. It did not last more than a couple months, and then he progressed, and we were not able to get him to allotransplant. But the thought is that for this specific subtype of disease, or maybe some other diseases that have this very specific JAK2 fusion that may be really oncogenic in those tumors, could single agent activity be a JAK inhibitor be used, and could that be a bridge potentially to curative therapy? So more to go there, but it looks like there may be a subset of patients that are quite susceptible. I think the other pathway that we've really looked at more extensively is the PI3 kinase pathway. If you're following the FDA, there's been a lot of discussion about the safety of these drugs, and certainly the long-term data for low-grade B-cell lymphomas like CLL or follicular lymphoma suggests that they may add important toxicity with chronic use, including things like immunosuppression. I think in T-cell lymphoma, we're not quite at the point where we have an ibrutinib, where we have other safe therapies as an alternative. So we're really looking for drugs just that can control disease, get it better, either for some period of time or as a bridge to transplant. So what was the planned registrational study of duvelisib was something called the PRIMO study. So single agent phase 2 of duvelisib monotherapy in relapsed or refractory T-cell lymphomas. The phase 1 showed about a 50% response rate in a small number of patients, so the phase 2 expansion was done. And this is the updated data from ASH last year. The study is now completely accrued, but we don't have final data yet. A couple things to point out. When we looked at different dosing of duvelisib in T-cell lymphomas, it was noted from the phase 1 that most of the responders got a higher dose than 25 milligrams twice daily, which was the FDA-approved dose. So in some early dose finding, it looked like 75 milligrams was better at achieving disease control. So we start with that, and then in patients who are responding, drop to 25 because there looks like there's less long-term toxicity at that lower dose. Here you can see the waterfall plot showing that most patients respond. And if you just look at the numbers for the first 78 treatments that had 78 patients that had at least 6 months of follow-up, that was shown at ASH, The overall response rate is, again, hovering around 50%, and about half of those, or a little more than half of those, are complete responders. So we do see good activity with this drug, certainly comparable to available agents we have, like romidepsin and pralatrexate, and maybe even higher. We looked at combination of this to try to improve the activity, and this was a parallel phase 1 studies. We looked at combination of duvelisib with romidepsin, another active agent, or with bortezomib. Each of those had a preclinical rationale, and I'll show you some of that data. This study is now done. The bortezomib data was harder to combine duvelisib with, so we really ended up focusing and expanding the romidepsin combination, where we saw relatively high rates of response. So this is the over 50 patients treated with peripheral T-cell lymphoma. The overall response rate was 58%, complete response rate 42%, particularly high in patients with follicular helper T-cell or angioimmunoblastic T-cell lymphoma, with an overall response rate of 68% and a 58% complete response rate, getting into smaller numbers, but high rates of response and fairly good success in bridging patients to allo transplant with curative intent. I think the other thing we saw with this, which was unexpected, was it actually looked like by combining it with romidepsin, we had some improved safety. So when duvelisib was looked at as a single agent at the MTD, which was 75 milligrams twice daily, which is what we give for T-cell lymphoma, there was about a 40% rate of grade 3 to 4, transaminase elevation. When we combine them with romidepsin, we see the rate of grade 3 to 4 transaminase elevation here at the MTD of just 14%. So just 8 of 59 patients at the MTD had grade 3 to 4 transaminase elevation, which was much lower than what was seen in the phase 1 study. The other thing that was interesting is there was a small arm in this study, which was a single agent duvelisib lead-in cycle. So in the phase 1 study, we didn't get as many tumor samples as we wanted. So in our combination study, we incorporated this lead-in cycle where patients got 1 cycle of single agent duvelisib just to get biopsies to just try to understand what we were targeting. And of the 10 patients who started with single agent single agent duvelisib, then with cycle 2 went to combination therapy, we saw that same 40% response, 40% rate of transaminase elevation, small numbers, but it looked exactly like what we saw in the phase 1, where if you started with the combination with romidepsin, only 4 of 49 patients had transaminase elevation. So we're trying to understand this a little better, but we think there may be some mechanism here where the romidepsin, in addition to potentially adding some additional activity against T-cell lymphoma, maybe adding some protection, maybe by suppressing some of the inflammatory T cells that lead to that. So that's still being worked out. But if romidepsin could add activity and reduce toxicity, that would be nice. Things don't always work out that well in oncology. So just to summarize the signaling pathways, I talked a little bit about targeting the JAK-STAT pathway. We saw a proof of principle study with ruxolitinib where we saw about a 30% response rate. There's other JAK inhibitors that are more specific. There's STAT degraders. There's a number of other molecules in this space that are being looked at, but we think as a principle, targeting the JAK-STAT pathway may be useful in T-cell lymphoma and possibly particularly useful in certain subtypes. Maybe those subtypes are LGL and some of these lymphomas that are characterized by JAK2 fusion. In terms of PI3 kinase inhibition, duvelisib, which is a delta gamma inhibitor, has completed its registration study, and we'll get those final results hopefully soon. Not sure what the FDA in the U.S. action will be on that because they've been very cautious about toxicities in PI3 kinase inhibitors, so that may need a follow-on combination study. There are other PI3 kinase inhibitors in the clinic or in development, and some of them in smaller data sets have shown similar activity in T-cell lymphoma. And I didn't go into the biomarker data, but at least right now for PI3 kinase inhibitors, we don't have a clear predictive biomarker of who responds. It's not something as simple as a mutation in the PI3 kinase pathway. It seems to be a little more complicated than that, but we're working on that. And then this is the current U.S. upfront trial, which looks at moving a couple of these strategies up front. So this trial is led by Neha Mehta Shah, who's at Washington University, and this is a randomized phase 2 study in the U.S. looking at CC486, that oral form of azacitidine plus chemotherapy, or duvelisib plus chemotherapy, or standard therapy, which is CHOP or CHOEP based on your age. And this is open now for patients with CD30 negative peripheral T-cell lymphoma, excluding those with anaplastic large cell lymphoma or high CD30 expression based on the Echelon-2 data. So I'll talk a little bit about immune therapies, then take questions. So in terms of immune therapies in T-cell lymphoma, this has been a little harder than in B-cell lymphomas, and we're still very in the early stages of understanding efficacy and, importantly, safety. So there are some bispecifics in clinical trials, one targeting CD30, AFM13. There's a PD-1 CD3 bispecific that's in early phase study for PD-1 positive T-cell lymphomas. Again, it's been a little complicated using good T cells to target malignant T cells in terms of concerns about safety and not activating the lymphoma, but these are early studies underway. There's been a little bit of data with anti-CD47 strategies, either magrolimab as a single agent, or there's a SIRP alpha decoy receptor from Trillium called TTI-621 that's had about a 20% response rate. So looking at those as ways of stimulating another arm of the immune system, macrophages, as a don't eat me signal. And then there's a number of CAR T cell ideas that are in early clinical trials targeting CD5, CD70, something called TRBC1, which is the constant region of the T cell receptor, and of course CD30. One of the ideas that I'll just explain now, one of the concerns in targeting T-cell lymphomas with cell therapy, particularly autologous CAR T-cells, is long-term T-cell aplasia, where with CD19 CARs, you may get long-term B-cell depletion, but that's relatively consistent with safety and healthy. We don't think we can deplete T cells long term. So this is a company called Autolus, Martin Poulet in his lab, and then spun out to this company looking at targeting TRBC1 or TRBC2. So your T cell receptor has a constant region, and through VDJ rearrangement, this is sort of like kappa lambda, the T cell receptor will be either TRBC1 or TRBC2. There are some very good antibody targets that are specific for TRBC1 that don't have much overlap. So the thought is if your healthy T cells have a mix of these and you get TRBC1, TRBC2, and CD4 cells, CD8 cells, so it's not specific to one population of T cells, can you isolate the malignant cells? Can you make a CAR T cell just targeting TRBC1? And then if you're effective against lymphoma, just deplete the TRBC1 cells, and the TRBC2 population should be able to reconstitute a normal immune system. So they had some early phase clinical data with showing a little bit of efficacy they presented at EHA last year, but that's just one of the strategies to try to get around the risk of long-term T-cell aplasia. The CD5 targets are using different strategies. And then the other strategy I was going to talk about a little bit is using non-autologous T-cell sources. So this is a study that we're participating in that Swami Iyer presented data at EHA last year using CTX130, which is a compound from a company called CRISPR, targeting CD70, which is frequent on T-cell lymphomas, but using allogeneic CAR T cells. So there's not a risk of transfecting tumor cells when you make your CAR construct because they're allo T cells, and the cells don't persist long term. So we'd like them to persist a little to be an effective therapy, but we don't necessarily want T cell suppression going on long term. And just some early data that Swami presented, that there are some responses. Some of these were transient, some of them are more durable in a small number of patients. So at the highest, or at the dose level 3, which he showed data on, the overall response rate in patients with T-cell lymphoma was 6 out of 10, maybe particularly good responses in patients with cutaneous T-cell lymphoma. So I'll just wrap up there in focusing really just on new targets. There's newer approaches, epigenetic therapies we use currently. Some of those are moving into the front line, and then valemetostat or EZH inhibition is sort of the newest mechanism that seems quite promising. In terms of signaling targets, while there's a number being looked at, the ones we have the most clinical data on are targeting the JAK-STAT pathway. There's some registration studies going on there, and targeting the PI3 kinase pathway, and we have some registration studies completed. And then I think the next step for the targeting, for the signaling targets will be, can they be combined either in the relapse setting, or is there a role to combine them up front? I think for immune therapies for T-cell lymphoma, we're quite early. There's a number of strategies in development. How effective they are, do we get durable responses, how safe they are, sort of still to be seen. And a lot of the studies are really in phase 1. So there's a lot of effort being done there, but I don't think we yet know what's going to come to the clinic in a consistently useful way. And I think as we and others think that T-cell lymphoma is a group of 30 or so heterogeneous diseases, there is for sure going to be different strategies for different subtypes of disease. Some of those may be subtypes like AITL or ALCL, and some of them may be molecular or genetic subtypes based on what's going on inside the cells. And then again, our goal really to cure more people is to move these things to the upfront setting, try to identify active agents, try to figure out which subtypes of T-cell lymphoma are most vulnerable, and then really try to focus on those populations. So hopefully we're still on time, and I really appreciate your time and attention, and happy to take questions.